Hey guys, my case study was on chronic obstructive pulmonary disease, also known as COPD. Alright, so COPD is a progressive disease that obstructs airflow through either chronic productive cough or through destruction of the alveoli. This also includes chronic bronchitis and emphysema. What happens is there's a decrease in airflow from the lungs, and it results in less oxygen traveling to the body, making it harder for the body to get rid of carbon dioxide. So many COPD cases go undiagnosed for a very long time until it's very well advanced. So this makes it the third leading cause of death in America. And smoking is obviously the primary risk factor. What happens is the chemicals in the cigarette smoke swell up the airways, and it reduces the lungs' ability to fight off infection. Other risk factors are air pollution, secondhand smoke, history of childhood infections, and occupational exposures. Symptoms include chronic cough, labored breathing, shortness of breath, cyanosis, clubbing, frequent respiratory infections, fatigue, and more. Malnutrition is a common diagnosis because food intake decreases due to an increase of carbon dioxide, making the COPD individual feel extreme fatigue and physical exhaustion, so they don't eat as much. Alright, so like I was saying, with COPD patients, they have a decrease in their oxygen content, and they have an increase in carbon dioxide. They also have an increase with bicarbonate and white blood cells, and even their partial CO2 is elevated. And then they have low total protein, low albumin, low prealbumin, and also their red blood cells count is low. Alright, so my patient is on a few medications. She is on Comvevent. It's a bronchodilator. She does this at home. She takes 2 inhalations 4 times a day. This is used to open and relax the bronchial tubes and relieve shortness of breath. She's also right now on the Solumendrol. It is used to reduce inflammation in the bronchial tubes. She is also on Ansef, which is an antibiotic to treat bacterial infections. And she is taking albuterol and ipratropium bromide via the nebulizer. And again, these are to relax and open her bronchial tubes to relieve shortness of breath. Alright, so a little client history on Louise Hoffman. She is a 62-year-old white female. She was diagnosed with stage 1 COPD 5 years ago. She has no occupational exposure because she is a retired office manager from an independent insurance agency, but she does have history of bronchitis and upper respiratory infections during winter months for most of her adult life. She has no surgeries. Like we said before, smoking is the primary cause of COPD, and she was a smoker for 46 years, but she hasn't smoked in the past year. Her mother and her 2 aunts died of lung cancer, and she is married, and she lives with her husband. Alright, so she is currently at 119 pounds. She is only 5'3". Her BMI is 21. Her ideal weight is 115, but her usual body weight is around 145 to 150 pounds. And her last recorded weight was last year at 139 pounds. Alright, for her nutrition-focused physical findings, her heart is at a regular rate and rhythm. There's mild jugular distension noted. She's alert and her cranial nerves are intact. She has +1 bilateral edema. She has no cyanosis or clubbing. Her skin is warm and dry. Her chest and her lungs are very important in her situation. So right now she has decreased breath sounds. Percussion is hyper-resonant, which means that there's just an exaggerated longing sound in there. She's got prolonged expiration with wheezing, bronchi throughout, which bronchi means just a whistling sound when they're listening to her lungs. And she's using accessory muscles at rest. Alright, so Louise Hoffman's diet or appetite is very poor at the moment. With her COPD, she's only eaten a few bites because after she prepares her meals, she is extremely exhausted. So she has been eating the past few days. She also says that her foods don't taste the same. There's a bitter taste. She doesn't have an allergy to milk, but she stays away from it because people have told her that it increases mucus production, and with COPD, her mucus production is already increased. She says she does her own grocery shopping and meal preparation, but her daughters help out sometimes. She's not taking any supplements, nothing for vitamin or minerals. She doesn't drink alcohol, and she was diagnosed with this 5 years ago, but she says she was not given any nutrition therapy at all. Her 24-hour diet recall is not very much. She has a half a cup of coffee with non-dairy creamer. She had a few sips of orange juice, a half a cup of oatmeal with 1 teaspoon of sugar, 3/4 cup of chicken noodle soup with 2 saltine crackers, half a cup of coffee again with non-dairy creamer, and she likes to sip her Pepsi throughout the whole day. And it's estimated that she drinks about 32 ounces a day. For her diagnosis, I diagnosed her with inadequate energy intake related to increased fatigue and decreased ability to consume sufficient energy intake, as evidenced by the patient states she's too tired to eat after preparing meals, and her current energy intake of approximately 1,070 kcals. And also inadequate protein intake related to poor appetite, as evidenced by her 24-hour food intake compared to her estimated protein needs of 65 to 92 grams of protein a day. For Louise Hoffman's nutrition prescription, I put her on a high energy diet between 1,350 calories and 1,620 calories a day. Also, for her high protein diet is again between 65 grams to 92 grams of protein a day. So for her goals, we don't want to really go overboard. We want to start small. So we are going to start with advancing her energy intake to the low number of 1,350 kcals a day. And then with her protein, we want to advance to the lower number of 65 grams of protein a day. My recommendations for Louise Hoffman was to increase her intake by choosing high-calorie foods, and she can do that by adding healthy oils like olive oil and cottage cheese and yogurt. 2% or whole milk would be good also for increasing her protein intake. And the foods we talked about were eggs, milk, cheese, I said yogurt, of course meats, poultry, fish, nuts, and beans, and maybe an insure. And to monitor and evaluate, the indicator will be to monitor her tolerance of increased energy and protein intake, and the criteria is to see if she can meet the minimum of the 1,350 calories a day with the 65 grams of protein a day. And that's it. Thank you.